Thank you very much. Good morning, ladies and gentlemen, dear colleagues. First of all, I would like to thank John for inviting me and also the organizers. It's a great honor for me to participate in this very interesting and outstanding meeting. Now, we have a couple of various diseases which can cause dysphagia, and I would like to focus on Zenker's diverticulum, eosinophilic esophagitis, peptic esophageal stenosis, malignant esophageal stenosis, and motility disorders of the esophagus. Now, for diagnosis, it's very important to study the case history and to ask important questions to the patients on the onset of symptoms, in particular motility disorders. Patients may have a long history, location of dysphagia, asking the patient if they have problems just at the beginning of swallowing, or, for example, in case of Zenker's diverticulum, or are they able to swallow, but then they feel an impaired passage of food or fluids. We have to ask about the frequency and intensity of dysphagia and associated symptoms like regurgitation, chest pain, or weight loss. For further diagnosis, we usually recommend to start with gastroscopy, because in many cases we can make the diagnosis just with gastroscopy. It has to be complemented by an esophagogram, in particular in case of tight stenosis of the esophagus, which cannot be passed with an endoscope, or in case of motility disorders. Of course, manometry is the gold standard for differentiation of motility disorders, and CT scan and endoscopic ultrasound may be needed for extraluminal tumors and, of course, for cancer staging. Now, Zenker's diverticulum was initially described by the German surgeon Zenker from Munich. It's a disease of elderly patients, and it's caused by a loss of relaxation and fibrosis of the cricopharyngeal muscle. And this is a high pressure zone, causes an obstruction, and due to the high pressure, finally, it leads to a pulsion diverticulum through the muscle layer. The diagnosis can be easily made by an esophagogram, as we can see here, filling of the diverticulum with contrast at the beginning of swallowing, and also by endoscopy. We see here a tube. This is the esophageal lumen in the esophagus, in the lumen, and this is the diverticulum. And therefore, it's always very important to insert the gastroscope under direct vision. Otherwise, the tip will move into the diverticulum with an increased risk of perforation. A diverticulum can be resected, of course, but in the last 2 decades, it has become more and more common to cut the septum between the esophageal lumen and the diverticulum. So this is the septum with the cricopharyngeal muscle. And this can be done with rigid endoscopes, usually performed by ENT physicians, which has to be done under general anesthesia. And it's very effective. It's usually done with a CO2 laser. And with flexile endoscopy, we more or less mimic the same technique. And usually we prefer to do it by use of a special oval tube, a so-called flexible diverticuloscope. It's not a scope itself, but the name comes from the rigid instrument, which is used by ENT physicians. And this allows to position a shorter flap into the diverticulum, so this part, and the longer one into the esophageal lumen, so that the septum is exposed in between. And then we insert the endoscope through this tube, and we have a nice exposure here. And the aim is to cut the diverticulum, and this can be done with various types of knives or also with endoscopic scissors. And finally, you may just place clips to minimize the risk of perforation. This is a quite simple procedure and doesn't take more than 15 or 20 minutes. So this graph is from our initial publication in 30 patients whom we followed for more than 2 years after endoscopic myotomy, and we asked the patients to quantify the symptoms depending on the type of fluid and food, how the process of swallowing was impaired. So 0 means no problems at all, and 10 is complete inability to swallow. And as we can see here, the blue bars before treatments, especially for solid and very solid food, patients were very symptomatic, and we see a dramatic improvement even 2 years after treatment. So this seems to be durable. In our own experience, the procedure has to be repeated at some time in about 1/3 of the patients, but it's very easy because of scar formation, so the septum may recur to some extent, but it's relatively simple to repeat it. So a very effective treatment even for elderly patients. On contrast, eosinophilic esophagitis is usually a disease which is seen in young patients, initially described in children, but it can be also seen in adults, but usually the patients are young. And many of them have a long history of dysphagia when you ask them in detail on swallowing. And some have just occasionally symptoms due to food impaction. So in any case, when patients come with repeated attacks of food impaction, you should always think about the background of eosinophilic esophagitis, and some have also heartburn. The cause is unknown, but it's obviously there is an association with allergic diseases. It's also known as an allergic esophagitis. We see typical endoscopic signs, narrowing of the lumen, so quite often it's impossible to pass a regular gastroscope, and we have to switch to a pediatric gastroscope. We see this whitish tissue scars, this ring-type narrowing of the esophageal lumen, and it has to be confirmed by histopathology, so we take biopsies and we see an increased number of eosinophilic cells in the biopsies, and also depending on the duration of the disease, more and more fibrosis, and also the esophagogram is quite typical. Treatment should be based firstly on dietary modification. We should minimize, of course, the exposure to food allergens, and also recommend in some cases elemental diet. This is the most important part of treatment. I mentioned that some patients have heartburn, and a portion of these patients benefit from treatment with PPI. In addition, then topical fluticasone, so in particular budesonide, should be swallowed twice daily after main meals. And only in severe cases when we have an advanced stage of fibrosis and patients do not respond to this basic treatment, we should consider dilatation, either with buginage or with balloon dilatation, but this is associated with an increased risk of perforation. Here, as you can see, we did it very carefully, but we can already see the exposure here of the muscle layer. Peptic stenosis is caused by severe reflux disease, and the diagnosis can be made again by endoscopy. We see these inflammatory changes, the tight stenosis here. Of course, we should take biopsies to rule out malignancies. And treatment is done by dilatation, either with buginage or with balloon dilatation, as we did here. So there is no significant difference in terms of efficacy and safety. And after dilatation, we can nicely see here the large hernia, which is quite common. So this is the level of the EG junction with the stenosis, and this is the level of the diaphragm, and in between we have the large hernia. In refractory cases, we can also consider to cut the scar of the stenosis, and rarely temporary fully covered stents can be considered for treatment. Malignant stenosis can also be seen usually and diagnosed by means of endoscopy, as shown here. Dilatation of the esophagus, we see obviously an interluminal tumor here. We couldn't pass the stenosis, and therefore it's complemented by an esophagogram showing here a tumor at the EG junction infiltrating the fundus of the stomach. And of course we have to confirm that with biopsies. And when the diagnosis has been made, the second step is then staging, in particular by CT scan, and then the further treatment of the patient is discussed in tumor boards. So when patients are candidates for palliation, then of course management of dysphagia is a very important step. Here we see the tumor compressing the esophagus. Patient was inoperable due to high surgical risk factors, so it was quite difficult to pass the stenosis, but it's not necessary. Finally, it's enough if you pass a guide wire, and then a self-expandable stent is fully released. The introducer catheter is removed, and this again can be done just under sedation of the patient. And finally we see the upper part of the stent, which can now be easily passed with the endoscope, and we see the lower part of the esophagus, so complete restoration of swallowing. Motility disorders usually require additional investigations, in particular esophagogram and manometry, and this is just an example here. A patient we saw a couple of days ago with recurrent attacks of dysphagia, and we can nicely see firstly here a small impression of the esophagus at this level. This has to be further clarified, but also here spasm at the distal esophageal part. You see here in the lateral position, here are some spasms which may cause dysphagia, and this has then to be further studied by manometry. And high-resolution manometry is now the best option for differentiation of motility disorders, and this is an example in a patient with achalasia. We see here the upper part, the upper esophageal sphincter with a high pressure zone, and then no peristalsis of the tubular part of the esophagus and an incomplete relaxation of the lower esophageal sphincter. So we can easily differentiate all different types of motility disorders, and I would like to focus to achalasia, which is a rare disease with an incidence of 1 per 100,000 per year. There is no association with gender or race. Age at diagnosis usually between 20 and 40 years, and the pathophysiology is not well understood, but there is increasing evidence that loss of inhibitory nitrogenergic neurons in the esophageal myenteric plexus cause aperistalsis and an impaired relaxation of the lower esophageal sphincter. And the current hypothesis for the etiology are that environmental factors, for example, viral infections, can cause a myenteric plexus inflammation, followed by an autoimmune response, and finally cause a destruction of the inhibitory ganglion cells. So it's very important to quantify the symptoms, and the Eckardt score is very easy to apply, and it's used in most of the publications. And this considers the main symptoms: weight loss, dysphagia, chest pain, and regurgitation, and depending on the intensity and frequency, we can determine the score. And this is also important for comparison of different treatment options and success of therapeutic interventions. So as I mentioned before, endoscopy is not very accurate in making the diagnosis. It's positive in only 1/3 of the cases. We can see in these cases either dilatation of the esophagus, food remnants. We have an increased resistance when we pass the cardia, but even a normal gastroscopy does not exclude a motility disorder and achalasia. Radiology is more helpful. It's positive in 2/3 of the cases. Either we see a dilatation of the esophagus, sometimes this bird peak type opacification here of the EG junction with a narrowing here and no relaxation, or depending on the type of dysphagia, we see spasm here in the distal part of the esophagus. We should classify achalasia in 3 types according to the suggestion of the Chicago group. So type 1 is the classical type with minimal esophageal pressurization, so there's more or less no peristalsis in the tubular part, no relaxation of the lower esophageal sphincter. Type 2 with simultaneous contraction, and type 3 with massive spasm here of the mid and lower part of the esophagus. Concerning treatment, we should always keep in mind there is no curative option. There is no treatment which can restore the destruction of the myenteric plexus and of the denervated esophagus. And therefore, it's more or less a palliative treatment aiming at a reduction of the gradient across the LES. And the aim is to relieve symptoms, to improve esophageal emptying, and to prevent development of a megaesophagus. Pharmacological treatment is not very effective. In particular, calcium channel blockers are usually not effective. We can consider endoscopic Botox injection, but this usually helps only for a short time. It's only for elderly patients with high risk factors for any kind of more invasive treatment. The majority of patients is treated with a disruption of the LES, either by surgical myotomy, pneumatic dilatation, or recently endoscopic myotomy has been introduced. An important randomized controlled trial was performed in Europe to compare pneumatic dilation with laparoscopic Halles myotomy, which is usually always combined with fundoplication because of the high incidence of more than 50% of reflux disease after surgical myotomy. And the results in more than 200 patients indicate there was no significant difference in terms of the therapeutic success, about 90% with both kind of treatments, and also no difference in terms of the LES pressure, abnormal acid exposure, perforation in 4% after pneumatic dilatation. So initially they started to dilate with a balloon with a size of 35 or even 40 millimeters, and then after they had this high incidence of perforation, they started with 30 millimeters, which we also recommend in the first session. Mucosal tears were seen in the Halles myotomy group, but these are clinically completely irrelevant. So no significant difference in terms of efficacy and safety. However, we should consider, if we look at details of the protocol for pneumatic dilation, all patients underwent a so-called dilation series. That means at least 2 dilations in all cases, and a third one if the Eckert score was still more than 3 after 4 weeks. In case of recurrence, patients underwent a second series of these dilation, and this was required in every 4th patient, and a third series was even done in case of recurrence after more than 2 years of the second surgery. So that means this is the main drawback of dilatation. It has to be repeated, and there is also a clear correlation with the age of the patient. The younger the patient, the worse is the outcome of pneumatic dilation. The recurrence rates are much higher in young patients. So then POEM was introduced per oral endoscopic myotomy, initially performed and in humans described by Inoue, who is here among the faculty. And this is done also under general anesthesia, but with flexible endoscopy through the esophageal lumen. A small incision is done in the mucosa, and then a submucosal tunnel is prepared down to the cardia 2 centimeters below the EG junction. So very similar as surgeons do from the laparoscopic approach. It's followed by myotomy below the EG junction, and then, and this is the interesting and important part of the procedure, the mucosal incision is finally closed with clips so that there is no risk of any leakage. And these endoscopic pictures, 2 centimeter incision of the submucosa, preparation of the tunnel. This is the backside of the mucosa. This is the muscle layer. And then the muscle is cut here. The longitudinal part is left, but this is also still an open question. We can also easily do a full myotomy, and then the incision is closed. And just to show you how precisely the preparation and the cutting can be done. This is the submucosa filled here with water. This is done with a water jet assisted knife, so we can not only inject but also cut and coagulate, and we can precisely cut on top of the muscle layer. So this is the backside of the mucosa. The tunnel is prepared below the EG junction, and then followed here by cutting of the muscle layer. So here the circumferential layer is cut and the longitudinal layer is left, and at the EG junction, and this is also done by many other institutions, a full myotomy is done at the EG junction because it's also more difficult to differentiate the muscle layers. And now you can nicely see the nice opening now of the esophageal lumen, and then subsequently clips are placed. And the advantage is also that we can extend the length of myotomy even to the mid and proximal part of the esophagus, and this seems to be the only option for patients with nutcracker esophagus or jackhammer esophagus, because this cannot be done with the surgical myotomy. The length of myotomy is limited to about 7 to 8 centimeters into the esophagus. So I only show you the initial publications from Inoue, from a German and Italian group, and they confirm the procedure time is now about 60 to 90 minutes, I would say, after some experience. The length there varies. This is still open how far we have to cut in type 1 of achalasia. Symptomatic improvement is obtained in more than 90% of the cases, and also the objective parameters, decrease of LES pressure, can be seen in nearly all cases. Major complications seem to be rare. Of course, we have to wait for more long-term data, and in particular, we have to study the occurrence of GERD, which can be seen in 15 to 20% of the patients, but these patients very well respond to treatment with PPI. So current status is that POEM seems to be as effective as laparoscopic myotomy or pneumatic dilation. It's obviously less invasive than laparoscopic myotomy because the surrounding tissue at the EG junction is not injured. It seems to be at least as safe as pneumatic dilation, but more durable. And it could be effective in failures or predictable negative outcome of other interventions, laparoscopic myotomy or PD, especially PD in young patients, as I've mentioned before. And it allows myotomy in any direction and any length. It should be limited, what we think, to centers with expertise in advanced therapeutic endoscopy and/or laparoscopic or thoracoscopic surgery, interdisciplinary approach, and patients should be enrolled in carefully designed clinical trials. So I hope I could emphasize that we have a large spectrum of diseases which can cause dysphagia. So again, it's very important to have a detailed history of the patients, ask them for their specific symptoms. We have excellent diagnostic tools and also therapeutic measurements for our patients' care. Thank you very much.